Microbiology Part 2 lecture. So in review of Intro to Microbiology, there are 4 types of microbiology organisms. There's bacteria, fungi, viruses, and parasites. Bacteria can be classified as either pathogenic or normal flora, pathogenic meaning they are disease-causing, and normal flora meaning they do not cause disease. Bacteria can also be classified whether they are aerobic, meaning they need oxygen, or anaerobic, meaning they do not need oxygen. Specimens collected for microbiology. This is very important for the medical assistant to understand how to collect microbiology specimens. This is our main job duty in microbiology. There are several types of ways that we can collect microbiology specimens. We have swabs for wounds, abscesses, throat, ears, and eyes. We have sputum, urine, feces, which can be for bacterial culture or an ova or parasite, nasopharyngeal swabs for RSV or influenza, and then a pinworm prep for pinworms. Transporting specimens for microbiology, so bacteria is always transported in an Amy's or a modified Stewart or Bacti swabs. Transport swabs can also be called culturette swabs. And a lot of times, some of these transport media have dual swabs, so we can do the on-site rapid test with one swab and then send the other swab for a culture. Viruses are collected with an M5 or M5RT. Fungal specimens are collected with a sterile container if it is hair, skin, or nails, or it can also be transported in a transport media if it is a swab. Sometimes we will do this for our wounds. Parasites will be collected in a special ova and parasite transport container depending on what type of parasite it is and what the nature is, if it is fecal matter or not. Wound collection, we usually use a sterile swab. If we are looking for bacteria, we would then place the swab in an Amy's modified Stewart transport media. And to figure out which one it needs, you would consult your lab reference manual. We also need to consider whether it's aerobic or anaerobic or maybe both. So we would maybe do 2 swabs, one of aerobic, meaning a Amy's or modified Stewart, and then anaerobic, which would be our Stewarts with charcoal or Amy's with charcoal. For wound collection, the label is also very important. We would put the patient's name and the second identifier, meaning the medical history number or the date of birth. The date and time, the time should be always in military time, and then the site of specimen collection. And this needs to be very, very specific. It needs to be left posterior ankle, left anterior ankle, knee, whatever, wherever the collection was. And the importance of this is sometimes some patients will have more than one wound that will need to be swabbed, and they can have different bacteria growing in them. So we need to know which bacteria is growing in which wound so we can best treat the individual wound. You also need your collector's initials on the swab. If you're looking for a viral infection, you would then use an M5 transport media for those types of infections. And maybe sometimes a doctor doesn't know whether it's bacterial or viral, so you would do both. Sputum collection. So coughing up a mucus of the patient is what we are doing. So instruct the patient to expectorate or only sputum into the cup. Do not spit. Spit will contaminate the specimen and it will be rejected by the lab. So how do we know whether it is spit? Spit is generally clear and it is much, much thinner than any sputum. Sometimes your sputum will have yellow, greenish tinge or a bloody tinge, and that is okay, and obviously that's not normal, but that way we know it's more than just spit. We also want to give the patient the label containers. Not all the time can patients do this type of collection right in the office, because a lot of times for a sputum collection, it is best to do this first thing in the morning. So sometimes we will send a labeled container along with the patient in a biohazard bag for them to collect at home. Fecal collections, there are different reasons why we would indicate a fecal collection. Persistent diarrhea that is unresponsive to treatment, diarrhea with a fever over 101 Fahrenheit, or any bloody diarrhea. So collection methods, rarely a rectal swab, but it can be done, and then collection of the portion of the bowel movement, which typically is done either in the office or at home. A lot of times patients cannot have a bowel movement right in the office, so we will send the containers home with them. It is important that they are labeled and we give them the correct collection devices along with a biohazard bag, and a lot of times we will give them a urine hat to help collect some of the bowel movement so it's easier for collection. Especially for elderly people, this can be rather hard for them. We will sometimes evaluate intestinal parasites and their eggs, which also is called an ovoparasite, or abbreviated as an OMP. We also will test for the presence of enteric bacteria, so a stool culture or CNS, or Salmonella, Shigella, or E. coli, or C. diff. We can also test for the presence of white blood cells. So for C. diff and white blood cells, it needs to be collected in a sterile sage container. The Parapack with pink and gray will be used for Giardia, Cryptosporidium, or ovine parasite, and then the Blaricare, which is the orange top, is used for fecal culture, ovine parasite, Giardia, and Cryptosporidium. And sometimes some labs will have different collection methods that they want you to use, or whether the specimen should be refrigerated. So it's always important to consult your lab reference manual and take note of what your specific lab would like. Pinworm prep parasite is common in children. Worms live in the intestines and then they migrate out into the anus at night to lay eggs. It causes severe itching when hatching, so children who are itching their bottoms, this is a common observation from their parents, and this is what we suspect is pinworms. We will then use cellophane or tape, and we will place that across the anus, remove it, and then put it onto a slide and look at it under the microscope. Kits and instructions given to the patient to take home. A lot of times this is done at home because the best time for collection is right away in the morning before a bowel movement, urination, or bathing. This is what pinworm eggs look like on cellulose tape slide. Gram stain to prepare. We prepare it from initial specimen or from a colony off of a culture. It reveals the gram reaction, so gram positive, gram negative, and the morphology, so cocci, rods, or spirals. The purpose is to guide antibiotic therapy. For sputum, it also determines whether it was adequate sputum or if it was spit. Bacterial identification and antibiotic susceptibility it helps with. So preparing the gram stain, we would, from a swab, inoculate culture media first if there is only one swab available. Most of the time when we are swabbing a throat or any type of wound, we will do a dual swab to do initial testing in a rapid test kit, and then we would send the other one for culture. Or we can also do from a colony or a culture plate. So once we swab the slide with either a colony or the actual swab, we would then heat fix the slide, as you can see here. And there are a couple of different ways that we can heat fix the slide. We can do a methanol fix, or we can do a heat fix. The smear must be dry before we heat fix. It affixes the bacteria to the slide. That's the whole purpose of the heat fix, I should say. You want it to be dry before we start the gram stain. And we can either heat fix by holding it up to an incinerator, which is a little bit more dangerous as the slide can heat up and sometimes burn the finger if you get too hot or you leave it there too long. So a lot of times we'll use hot plates to heat fix the bacteria to the slide. It is important not to leave your slide on the hot plate or close to the incinerator, as you will damage the bacteria. So the gram stain procedure: fix the specimen onto the slide with either methanol or heat. Make sure your slide is completely dry before gram staining. You would then flood your slide with crystal violet, the purple stain, and then you would rinse the slide off after 1 minute, and then blot it dry with a paper towel, and then you would flood this stain with grams iodine for 1 minute, and then you would rinse it with water and blot it dry, and then after this you would decolorize it for 3 to 5 seconds with alcohol. The purple stain is removed from the gram negatives, but the gram positives will remain purple in this stage. Sometimes some people will then rinse to stop the decolorizing action. They will rinse this and then they will do the counter stain with the safranin, which will stain the gram negative cells reddish pink. The gram positive cells will then remain purple. And this all has to do with the dyes taking hold of the different cell walls among the different bacteria. So after we have the gram stain done, we would then put the slide under the microscope. We would put a drop of oil, immersion oil, on the slide, and then we would switch to 100x, and we would start the examination by determining whether it was gram positive, which is purple, or gram negative, which is red. So when we are observing the slide, we observe the morphology, so if they're rods, coccus, coccobacillus, or spirilla, and then the growth patterns, whether it's clusters, pairs, or chains. We want to read the gram stain or the slide using bright light microscopy, which is the exact opposite of urine. Stained specimens need lots of light. The bacteria are very tiny, and they are to interpret bacterial findings, use a 100x oil objective. You do not want to use 100x without oil, or you will shatter your slide. First, you will determine the gram staining characteristics, so if it's gram positive or gram negative. Then you will determine the shape, whether it's rod, cocci, or spirilla. And then you would want to quantify as few, moderate, or many of each type of bacteria seen. So here is a slide of a wound, and these are circular type bacteria. So you have cocci, it is purple, so you have gram positive, so you have, and they are in clusters, so you have gram positive staphylococci. Here's another picture of a wound, and it looks like it is purple, so gram positive. It looks like these are bacillus. They are a little linkier in shape, but they are in chains. So we have gram positive streptobacillus. So here's another picture. Looks like they are purple. This one's hard to decipher, a little bit blurry, but it looks like they are purple circles. So we have gram positive. And it looks like for the most part they are in pairs. So we have gram positive diplococci. So here we have red or pink, which would be gram negative. And it looks like they are in a circular type fashion. And it looks like they might be in pairs for the most part. So we would have gram negative, diplococci. So here we have purple circles, and they are in chains, as you can see. So this would be gram-positive streptococci. So here's a wound. This one's hard to see, also a little bit blurry. So these are reddish pink. So you got gram-negative, and they are circular, and they are in pairs. So you have gram-negative diplococci. So the culture and sensitivity test we talked about in the intro to microbiology. Culture is the identification of bacteria. The sensitivity is the antibiotic susceptibility in order to treat the bacteria that we've identified. So R means resistant. The bacteria will resist this antibiotic and live in the presence of it. S means susceptible. Bacteria are susceptible to the antibiotic and will not live in the presence of it. And I is intermediate. The bacteria show some signs of susceptibility, but then some signs of resistance. So when prescribing antibiotics and we're looking at the report, we always want to make sure the patient is on a susceptible antibiotic. Oftentimes when we are doing tests, we are swabbing them, and we might not have the results back for a couple of days after the culture is done. So a lot of times what will happen is the physician will prescribe an antibiotic and send the patient home, but we will still send the specimen for culture and sensitivity, even though we might not get the results back in 1 to 7 days. However, when we get that report back in 1 to 7 days, depending on the findings, we may need to switch the antibiotic. So it is the medical assistant's job to look at these reports and see, okay, the patient was prescribed amoxicillin, and this bacteria is resistant to amoxicillin, so I need to tell the physician, because we need to switch this patient's antibiotic. They are not going to start feeling better until we switch the antibiotic. And obviously, a lot of physicians have drugs that they go to for certain illnesses, and we know that strep throat is oftentimes, or a UTI is a good example. UTIs are best treated with Cipro or Macrobid, and we know that those drugs are most effective, so we will start the patient on that. Rarely will a culture and sensitivity report come back that those are ineffective for UTI. So, but we still have to compare them as the medical assistant and bring attention if appropriate therapy was not given to the patient in that initial visit. Antibiotics, so overprescribing antibiotics makes some bacteria resistant to antibiotic therapy. So if a patient was prescribed an antibiotic thinking that they had, say, strep throat, and we get the culture back and there is no strep throat, we would then call the patient and discontinue the antibiotic to kind of curve off some of the antibiotic resistance that is going on in the world. Two recent concerns, and actually they've been concerns for quite a while, but are still very, very prevalent, are MRSA, which is methicillin-resistant Staphylococcus aureus, and VRE, which is vancomycin-resistant enterococci. And these two are very, very much a concern and need high-powered drugs to treat them. So MRSA can only be treated by very select drugs. One of the main drugs that we treat MRSA with is vancomycin. But then if there is a vancomycin resistance that occurs, one of the only drugs that is available to treat vancomycin resistant enterococci is isoniazid that we oftentimes will use.